Okay, so let's talk about liver disease. Let's talk about a little bit about the normal liver disease and the injury pattern, and the normal liver and liver disease and the injury pattern that you see in liver disease. Sorry about that. Okay, so we are going to talk about this very important organ. A lot of people think that it is even more important than the heart because it is an organ that is involved in pretty much everything that happens in the body, from detoxification all the way to synthesis. Excuse me, just 1 second. I did, try to, uh, Hamad, correct me if I'm wrong. So how do you stop the transition? I want to do it manually. It is from transition, isn't it? Hello?
Yes, doctor. What is the issue?
Any idea?
What is it, doctor? What is the problem?
Right. Yeah, it's it moves, it transition from one slide to the other, like automatically, and I don't want it to do that. I want it to do it manually. How do you do this?
Honestly, I have no idea, to be honest. Maybe if
Right.
someone knows.
Anybody in the audience knows
Doctor, if you
anything?
could unclick after.
Sorry?
On the option on the top, the bar, there's something called advanced slide. There's on mouse click and after. If you unclick after, it will stop. Yeah.
That's
For
it?
each, yeah, but you must do that for each slide.
You want to do that for each slide, or it should be applied to all, isn't
You
it?
apply to all, yeah.
Okay. All right. So the hope is that it will not do this, right?
Sure.
Mhm. Means I need to stop sharing this and then share the new version. Okay. All right, that's all for the best. Okay, so as I mentioned to you, the importance of this organ. Now, I guess nothing happens. All right, so the most, we're talking now about the hepatic lobule, which is the functional unit of the liver, which is a 3D hexagon, with its tips made up of the portal triads. Okay. Now you can see also from this nice diagram is that the liver parenchyma is made up of, hepatic cords. Each one of this is a hepatic cords that is surrounded, that is usually 1 to 2 cell layer thick and surrounded from either side by the sinusoids. Okay. And it is designed that way so that the liver cells, the hepatocytes, will be able to reach out to those sinusoids for oxygen and and all kinds of supplies that they will work on in their metabolic, to metabolize or to convert or to detoxify or to do whatever, to sensitize, to make, so it is in direct relationship between, there's a direct relationship between this hepatic cords and the hepatic sinusoids. That's a very important relationship. All right, this is one. Two, the fact that actually the normal hepatic cords are made up of 1 or 2 cell, thickness is also very important, because the minute that you start to see, the layer upon layer of liver cells that are piling on top of each other, this relationship is no longer there anymore. The relationship between the liver cells and the hepatic sinusoids. And that happens in quite a number of diseases. Okay. Now, having talked about this, now you can actually divide the area between the central vein, which is right here in the middle, and the portal triad into three different regions. The first region is the area around the portal triad. This actually is known as zone 1. It's an area that is highly supplied by oxygen and by nutrients and supplies from the portal triad. Now, the region that is around the central vein is known as zone 3. As you can see, it is the most distal region from the portal triad. It is the area that is more prone to ischemia. And it is an area that also is supplied by, and that is actually, sorry, one second. That is, yeah. So it is an area that is, also very rich with detoxifying enzymes. So as a result of that, whenever there is an ischemic injury, this is the first region you look at under the microscope, zone 3. Whenever there is actually a toxic injury, this is the first area that you look at under the microscope. Okay, so zone 3 is a pretty vulnerable zone. Between them is zone 2, which is halfway, between the two of them. Now, another actually important, a feature that pathologists use when they look at the changes that are happening in the portal triad. In normal condition, there is what you call a transient inflammatory infiltrate that are present in this portal triad, what you call a standby inflammatory infiltrate, as you have seen in other parts of the body. There's always, a few lymphocytes here and there that are sitting, and they are, waiting. They are the guards, if you will, waiting for any kind of infection that is going to arise in this region, in order to recruit, to activate, and then you will see more cells that will be brought to the site in order to counter this infection. Now, so as long as these cells are few in number, this is 1, 2, they are limited to the portal tract. That's what you consider to be normal. When there is a large number of inflammatory cells that you see in the portal tract, that's when you start to wonder if you have something related to chronic hepatitis. Now, that is going to be confirmed, because again, what you may call a lot, others may call, normal. So one actually feature that is going to, cement your diagnosis of, or your suspicion of chronic hepatitis is going to be if the cells that are present in the portal tract spill over into the hepatic lobule, into the nearby hepatic lobule zone 1. Now, as a result of that, what pathologists actually designate is that the first layer of liver cells that separate zone 1 of the hepatic lobule from the portal tract is known as the limiting plate. So when they start to see that there are inflammatory cells that are spilling over from the portal tract into the zone 1 of the hepatic lobule over the limiting plate, they call that piecemeal necrosis or interface hepatitis, which is telling you that you do have actually chronic hepatitis. Okay, a very important point to keep in mind when you're looking at a histopathology slide in liver pathology. All right, so again, the 3 zones that we have talked about, here is the central zone. The area around it is zone 3. And then there is the zone around the portal tract known as zone 1. Between them, there is zone 2. Okay, now there are a lot of diseases that happen to the liver. There are a lot of pathogens. There are a lot of processes that may involve the liver. Some of it could be metabolic, some of it could be ischemic, some of it could be toxic, some of it could be carcinogenic, Some of it could be what else? Inflammatory. Some of it, like infectious. Some of it could be autoimmune, inflammatory, autoimmune. Luckily, when the liver responds to this kind of factors, it's going to respond in a limited number of ways. All right, so it is good that it's going to respond in a limited number of ways, but then if you look under the microscope, it's going to be hard really to differentiate between the different, processes that are happening in the liver, that may actually need, for example, immunostain, that may need, special stains, that may need, more work in order to reach, a diagnosis of the process that is ongoing in the liver. So the basic patterns of hepatic disease include necrosis. This is straightforward, which could be, depending on the severity, could be divided into massive, zonal, or focal. Now, degeneration, example of that, what you see with ballooning degeneration, which is a form of apoptosis that is seen usually in alcoholic hepatitis. Could be seen also in also steatohepatitis, could be seen also in viral hepatitis, as we would say. Now, inflammation could be acute or chronic. The acute usually is going to be mainly focusing on the lobule itself. So it's going to be in zone 1, 2, and 3, versus the chronic, which is going to be seen in the portal tract. You may see actually a confluent of the two processes. So you may see actually a lobular/portal kind of process that's gonna make it harder for you to figure out exactly, where did the process start and where did it end? Did it start in the lobule and ended up in the portal, or vice versa? Now, that's not going to be, only the only thing that you will look at, which is the histopathology. There are also serology tests that you can do that is going to actually direct you one way or the other. You may do some, molecular tests, PCR testing for Hep B or Hep C, that's going to be telling you what you're looking at. There may be also some immunohistochemical markers that you could do, for example, for hepatitis B surface antigen, that is going to highlight actually the presence of hepatitis B, surface antigen in liver cells. Now, also, you will see that there is a variable uh, kinds of cells that are involved in the inflammation of the liver. And we know that neutrophils are cells that are seen in alcoholic hepatitis. Plasma cells are cells that are seen in hepatitis A. We know that lymphocytes are seen usually in hepatitis B and C. And in hepatitis C, usually the lymphocytes will actually take the configuration of what looks like lymphocytic follicles. So each subtype of inflammatory cells will be more likely to be seen, with specific entity. Now, regeneration, this is a very important point for the liver cell. The liver cell has a very, powerful ability to come back from the death. So the stem cells of the liver are able actually to mount back, a response to any kind of injury that, that can, affect the liver. And I'm sure you have heard somewhere that taking 3/4 or 7/8 of the liver, as they call it in surgery, is not going to be the end of the story when it comes to the liver. This small piece of the liver that was left intact, because it was the only thing that was healthy, for example, will be able to grow back to normal, or to semi-normal liver size. Fibrosis is going to be there, and it's going to be a response to a long list of pathologic processes happening in the liver. And the fibrosis may actually be maybe going to be confluent, that is going to affect the majority of the liver. It may be actually affecting only the part of the liver that the process has affected. and it's going to interfere with a lot of processes that happen in the liver. For example, the intrahepatic circulation, going to be affected with the presence of fibrous tissue, which may raise actually the portal pressure, the pressure in the portal vein, and that may actually impede flow to the liver. Cirrhosis is going to be the ultimate organized form of fibrosis. That's when you start to see that the liver is zigzag, is crisscrossed with a numerous fibrotic patches that are going to split the liver into nodules. Now, the way to think about it is that this fibrotic process is there to protect the liver cell, from any kind of toxic effect. For example, if there is any kind of toxin that the liver is working on to detoxify, let's say it's alcohol, for example, or a drug, acetaminophen, or if the patient survives actually the acute insult. If it is this is even like more actually seen with the chronic processes such as viral hepatitis that may give rise to chronic hepatitis such as Hep B, Hep C, and hepatitis delta. So the delta antigen. So in this case, you have to think about actually the presence of the fibrous tissue as a defense mechanism by the tissue itself against the pathogen or against the process. Now that's really good because it will be able to preserve, a number of those actually liver cells intact. But in the process of doing so, it will lose the normal architecture of the liver. And as a result of that, you will start to see that there is going to be a high turnover rate of liver cells that are present in those nodules that result from cirrhosis. This is why we call them regenerative nodules, because after the death of those cells, the stem cells of the liver are going to regenerate a new line of cells in those regenerative nodules. So you can see that the cell cycle is going to become fast. And if you recall from the POD, when the cell cycle become fast, all kind of supervising, mechanisms of the genome of the cell may get lost or may get deficient, and that may introduce actually mutations to the genome. At one point in time, these mutations may become actually functional, if you will, or translatable, and that's going to be when the cell turns neoplastic. That's how actually carcinoma may resolve. So this is an example of what happened, in chronic hepatitis. You can see that the first step is going to be the presence of this, increased number, of inflammatory cells far more than normal, and then the spillover of these inflammatory cells into the, zone 1 of the hepatic lobule over the limiting plate that we have talked about, the imaginary limiting plate that we have talked about. Now, once actually it goes through this, limiting plate, now it is in the lobule. Now, these are inflammatory cells. They are going to work on the liver cells, destroying these liver cells. This is why we call it actually, piecemeal necrosis or interface hepatitis. Now, this is not gonna, stay here. It will start to spread from one portal triad to another portal triad, what you call actually bridging necrosis or bridging, inflammatory, process, because it's bridging two nearby or adjacent, portal triad. Now, inflammation is going to heal at one point in time, and the healing will happen by fibrosis. And the fibrosis is going to extend from one portal tract into the next portal tract, resulting in what is known as bridging fibrosis. The same process is happening between the other portal triad, resulting in the formation of this nodule, of this larger nodules. Not only this, you will see also that there are, bridging inflammation, bridging necrosis, also that is going to extend into the central vein, resulting in portal central, bridging fibrosis and the creation of, more nodules. Okay. So the bridging that will happen could be central, could be portal, or could be portal central. Now, of course, as a result of the ongoing process, it is hard to see where things start because you are going to look at one point in time rather than the actual sequence of events. It's going to be hard for you to tell where did the process start and where did it finish. For example, we know that actually with cardiac cirrhosis that is associated with cor pulmonale, the process is going to start at the level of the central vein. But if you look at a cardiac cirrhotic, liver, it's going to be very hard for you to actually to pinpoint the starting point of this process. Pathology did not lose its sense of humor, and here you see a horrible process that is seen in the shape of a heart, as you can see. What is seen inside this nodule is the regenerative nodule that we have talked about. Now you can see that the regenerative nodule, the normal architecture of the liver parenchyma has been lost. So you no longer see actually the normal relationship between the hepatocytes and the nearby hepatic sinusoid, especially at the area surrounded by the fibrosis. Maybe inside the nodule itself, there may be a remnant, there may be actually still some areas where you will still see hepatic cords made up of one or two cell layers surrounded by sinusoids from each side. But remember, the circulation has been now, has become dysfunctional as a result of the increased amount of fibrous tissue that is being laid in the perisinusoidal space. But this actually, especially this disruption of the normal relationship, is especially true in the peripheral region of the regenerative nodule. As a result of that, a lot of these hepatocytes will actually undergo death because they no longer are able to reach out to the sinusoids that is no longer there. There's only here fibrous tissue, and those cells will die. So there will be more regeneration. The fact that the cell cycle is going to increase is going to result in actually less supervision on the genome of these cells, which may introduce mutation, which may become meaningful at one point in time, and may become actually neoplastic, giving rise to hepatocellular carcinoma. Portal hypertension. How does portal hypertension come to happen? It is one of the ways that the liver is going to manifest its damage. Portal hypertension could be divided into three levels of damage, or three main causes, major causes for this process. One of them is actually prehepatic. Prehepatic portal hypertension is caused by a thrombus, a large thrombus that is going to actually occlude the portal vein. As a result of that, the pressure inside the portal vein is going to be increased. Okay. Now, it could be also from hepatic causes. The most common cause, from the liver, of portal hypertension is cirrhosis, and is also the most common cause of the most common overall cause of portal hypertension, cirrhosis, that is. All right. So, and finally, there is also the post-hepatic causes. The post-hepatic causes usually are due to actually occlusion, of the suprahepatic veins, or that's how it used to be called during my days. Now they call it the hepatic veins. There's a couple of clinical syndromes that you are going to be to see, if you have not seen already, probably in hematology, such as the Budd-Chiari syndrome, Budd-Chiari syndrome, and the veno-occlusive disease. So Budd-Chiari syndrome and VOD, veno-occlusive disease, are two diseases that may involve actually the hepatic veins and occluding them, and as a result of that, increasing portal, tension, portal pressure from, post-hepatic causes. Now, once actually there's going to be an increase in the portal, vein, from any one of these three causes, the end result is going to be a reversal of the flow of blood, from the GI into the portal vein and into the liver. As a result of that, you will start to see that the liver will be going back into the spleen, resulting in splenomegaly. the liver is going, the blood is going to go back into, wherever it finds that there is what you call a portosystemic kind of, kind of shunts, such as, the lower esophageal, veins, resulting in esophageal varices, or actually at the level of the, rectal veins, resulting in hemorrhoids. Also, that may actually go back into the umbilicus, resulting in what's known as a caput mediosa. Ascites also is a cause of this, actually, of this portal hypertension as a result of the backing up of lymph flow. Splenomegaly, as a result of the blood that is going back into the spleen, is going to act as a trap for blood cells, especially platelets, that will no longer be able to escape the splenic ports, and reach the peripheral blood. As a result of that, it will get stuck in the spleen, resulting in thrombocytopenia. You will realize, when you go into the clinical wards, that actually the thrombocytopenia, the more pronounced the thrombocytopenia, the more severe the cirrhosis of the patient. Here's a great picture from osmosis. You can see actually that I kept what do you call it? The sign of this great actually website, or this great YouTube channel. This is actually what is seen in normal condition. Let me show you what is seen in normal condition. This is what usually is seen in normal condition. This is from Golgi pathology, Golgi or Robbins pathology. You can see here that the hepatocytes are living happily. Okay, they are surrounded by this, perisinusoidal space. But the perisinusoidal space in normal condition is manned by a few number of actually stellate cells, also known as itocells. You can see that there is a very limited number of itocells in the perisinusoidal space. And they do organize actually a layer of collagen, but the layer of collagen that these cells lay down is very wispy, very fine, layer of collagen made up of actually type 4 collagen, which is a very highly specialized form of collagen that will allow, as if it does not really exist in this region. So it will allow for the free, movement of, of oxygen and nutrients, from the sinusoidal space and into the hepatic cells. Okay. Now, what happened actually as a result? Let's talk about this, from here. As a result of any kind of injury, toxic, infectious, autoimmune, mutagenic, what else? Metabolic, okay? Metabolic, that is going to affect the liver. The liver is ground zero, in terms of dealing with all kinds of insults that I just mentioned. What's going to happen is going to be the activation of the Kupffer cells. Once the Kupffer cells are going to be activated, they are going to make, cytokines. These cytokines, are specialized cytokines that do the following: either proliferation, such as the PDGF, the platelet-derived growth factor, or the tumor necrosis factor, that is going to exert its effect on the stellate cells that are manning the perisinusoidal space, making them divide and proliferate, filling up this perisinusoidal space, obliterating it altogether. Okay? That's actually the proliferating. Or it can be actually contraction. Remember that these actually stellate cells are not just fibroblasts, but they are myofibroblasts. So they have the ability to contract, which is going to add even more insult to injury in terms of its ability to contract and squeeze the perisinusoidal space and squeeze also the sinusoid itself and raise pressure inside the sinusoid, intrasinusoidal pressure that is going eventually to reflect back on the pressure in the portal vein, resulting in increased portal pressure, portal hypertension. Now, the third kind of cytokines that are produced by the Kupffer cells are going to be chemotactic. They are going to recruit more inflammatory cells, more fibroblastic cells to the site of action. One of them is the monocyte, monocyte chemoattractant protein 1, and again, the PDGF. So that is what you call proliferation, contracting, and chemotaxis. And you add to it also fibrogenesis, such as the transforming growth factor that will make these cells lay down, more collagen. But the collagen that is going to be laid down, following this type of injury, we'll see that the ito cells will be laying down now type 1 and type 3 collagen, which are very thick type of collagen. As a result of all the processes that I just mentioned to you, the end result is going to be filling up the perisinusoidal space with contracting myofibroblasts that are going to increase the pressure on the sinusoidal space nearby, and that are going to prevent the hepatocytes from reaching into the sinusoidal space, resulting in the death of those hepatocytes by apoptosis. Okay, so you can see actually what happened at the periphery of the regenerative nodule, as I mentioned to you a minute. All right, so end result is going to be death of these cells and raising the pressure on on here, and that's going to be really two manifestation of liver damage. Now, finally, the big elephant in the room, so to speak, is going to be the hepatocellular carcinoma. And here, the underlying process is going to be the ongoing injury. The ongoing injury and repair, the end result, increase speed of the cell cycle. And, also you add to it, the viral infection. The virus may itself actually be able to become part of the, what's called integrate with the liver cell, such as what you see, especially with hepatitis B. It may have a toxin injury and a mutagenic or carcinogenic injury, such as what you see with alcohol, or it may be a metabolic insult. It could be fat, it could be any kind of metabolites that will start to accumulate in the liver. So the whole effect of the injury and repair that may result from any one of those actually factors, is going to end up eventually causing, a neoplastic transformation and the development of hepatocellular carcinoma. Right? So here's an example of hepatocellular carcinoma that is arising in a background of cirrhosis. You can see that there are those patches of fibrosis that are crisscrossing and that are fusing really to create the the nodular appearance of the liver surrounding this part of the liver parenchyma, what is known as regenerative nodule. Unfortunately, in some of these regenerative nodules, you're starting to see that liver cells are becoming neoplastic and development of hepatocellular carcinoma. Okay. All right. So cirrhosis is going to be also one of the. So now let's talk about some. So we have talked about the patterns of injury. We have seen that the liver is going to respond to different insults the same way. Your mission as as the clinician is to figure out exactly what is causing this. And at your arsenal is going to be, a liver biopsy, is going to be serology, is going to be, molecular test, is going to be, and before all of that, of course, history is very important in this case. Okay. So that you're going to be using everything at your disposal in order to reach a diagnosis. Now, cirrhosis, is one of the clinical syndromes that you see in liver disease. Cirrhosis development depends on three processes or three phases, really. First one is the death of the hepatocytes. This is straightforward from any kind of, process, any one of the processes that we have talked about: ischemic, carcinogenic, mutagenic, toxic, any one of those, infectious, autoimmune. Then there's the extracellular matrix deposition, and finally, a very important one, what's known as the vascular reorganization. Now, one that is particularly interesting is the extracellular matrix deposition, because in normal liver, you will see in the capsule, also in the portal triad, and in this around the central veins, you will see that types of collagen are 1, 3, 5, and 9. Now, normal hepatocytes per se do not really have a basement membrane, but they do have actually a delicate framework of collagen type 4, as I mentioned to you, which is situated in the space, the perisinusoidal space, that is separating, the sinusoidal endothelial cells and the hepatocytes. We did talk about this a minute ago. All right, so the pathogenesis, this is just going over what we have talked about for those who like to read. But add to it, the vascular injuries that, as I mentioned to you, are very important. What kind of vascular injuries do you see in cirrhosis? The first one is going to be the loss of sinusoidal endothelial cell fenestration, which will ensure that there will be no reaching out of the liver cells, into the sinusoidal space and getting, their oxygen, their supplies, their nutrients from the sinusoidal space. And also, very importantly, the development of portal vein, hepatic vein, and hepatic artery, portal vein, arterial venous shunts in the fibrotic strands, of the cirrhosis. Now, that's a very important, especially this one right here. Now you're moving actually, or you're putting an arterial system into the venous system. What happened to the venous system in this case? The pressure in the venous system is going to increase. And that's going to be an added factor why those patients actually develop portal hypertension, because of these shunts that are present in the fibrotic veins. Here's a nice actually picture of normal liver that is highlighted by type 4 collagen. And you can see that the type 4 collagen layer is very thin, what you call wispy, or fine, if you will. And it is interrupted. It is not complete. And all of that is by design, because you don't want it thick and you don't want it continuous, because you're putting it there in order to allow actually the exchange between the hepatic cells and the sinusoids. So this is normal. This is the abnormal. Here you see actually the transformation of collagen from normal into abnormal. So with abnormal, you will see that the type of collagen that you will see in the regenerative nodule is going to change from type 4 collagen to type 1 and 3, and it's going to become thicker and more continuous. You can see that even within the nodule itself, those lobular patterns are complete. It's not interrupted layer anymore. And especially in the periphery, as I mentioned to you, it is the sickest in the periphery. Of course, the stain that we use to highlight this is reticulin stain. All right, now portal hypertension, as I mentioned to you, the three causes: prehepatic, hepatic, and posthepatic. So we can go over this quickly. What is the pathogenesis? This is an important, question in any exam. So one is going to be the increased resistance of blood flow at the level of the sinusoid. You have seen that in this picture. Okay. And why there is increased pressure? Because of all the good stuff that are accumulating here. All the idle cells that are now, that are bad actually actors, because they are becoming continuous layer. 1, 2, they are laying down type 1 and 3 collagen, filling up this area, compressing the poor sinusoids, raising its pressure. So that's number one. Okay. Then there is also the compression of the central veins by the fibrous tissue nearby. And also, as I mentioned to you, the venous arterial shunts that are present in the fibrotic veins of cirrhosis. There's also one more actually factor why you have portal hypertension, why a patient with liver disease may have portal hypertension. So remember that everything now is going back to the liver in a very slowed fashion. It's still going, it's still coming in, but very slowly. As a result of that, there's a lot of bacteria in the GI that are going to die, leaving their DNA back, but its DNA is not going to be cleaned up, fast enough. As a result of that, the inflammatory cells in that site are going to be releasing the nitric oxide, which is going to result in vasodilation. and that's going to result in hyperdynamic circulation, which is going to increase the portal tension. This is in the picture again. So here you will see, actually, if you want to think about what's going on in the liver of someone who's cirrhotic and have developed portal hypertension. So as a result of the backup of the lymph, you will start to see accumulation of this fluid in the abdomen of the patient. So there will be ascites, okay? And as a result of the backup, of the blood in the spleen, you will see an enlarged spleen and splenomegaly with this thrombocytopenia. There may be actually a hepatic, syndrome that may be actually getting kicked in, and also renal, or hepatorenal, failure or hepatorenal syndrome that also may actually be activated. So resulting in what you call multi-organ system failure. Now here's another actually picture that is going to show you everything in a nutshell. So you can see, as a result of the cirrhosis of the liver, there is a backup of the lymph in the abdomen, from the flow into the liver and into the portal circulation. So the resulting in ascites, you will see that as a result of the backup of blood, from the portal circulation into the systemic circulation, you will start to see the caput mediosa in the periumbilical region, splenomegaly. You may also see that there is esophageal varices and there is hemorrhoids as a result of the fact that the estrogen are no longer actually being, metabolized in the liver. The end result is going to be testicular atrophy in those patients. And the fact that actually now a lot of the toxic metabolites are bypassing the liver and going into the systemic circulation, hepatic encephaly may actually may set in. What are the liver function tests? You will see that there is a long and different, list between different countries, between different institutions sometimes. The four that, I got to learn in the US are bilirubin, that looks at the synthetic. So bilirubin, the prothrombin, and the albumin look at the synthetic function of the liver, and the ALT looks at, the liver enzyme status. Okay, so this is actually lecture 1. If you guys want to ask a question, feel free, or we may continue into lecture 2.
Doctor, could you re-explain how the bacteria plays role in cirrhosis?
Bacteria, not in cirrhosis, but in portal hypertension. Correct?
Yeah.
Yeah, so actually what happened, so, usually there are a lot of, there is bacteria in the gut that dies, right? And, the byproduct of its death or its demise is going to be, again, all taken up to the liver, and the liver is going to actually work on this and degrade it. Now, what happens actually when there is increased portal pressure, this process is going to slow down. So there will be, leftover, of the DNA of this bacteria that eventually is going to find its way to the liver, but it's not going to be in the right time frame, if you will, to take it to the liver, as a result of the fact that it is lingering outside, in the gut and clear. The end result is going to be the release of the nitric oxide, which is a vasodilator, by the inflammatory cells in that region, and that's going to result in increased, once you have vasodilation, there will be more flow, okay, and the more flow is going to add actually more pressure in the portal system, exacerbating the portal hypertension. Okay.
Yeah, thank you.
Thank you. Anything else?
Doctor,
What
for the
about
same one,
AST? All right, what about AST? AST is good, but AST is usually used for alcoholic disease. Okay, so ALT is more of actually the status of the hepatocyte itself. And when they look at how the liver cell is doing, they look at the ALT rather than the AST. If they are looking at alcoholic hepatitis, they look at the AST rather than the ALT. I mean, they look at both, but they will be more concerned with the AST in alcoholic hepatitis. Okay. Anything else?
Doctor, for this one, for the gut bacteria one, the infection can be anywhere, right? It doesn't have to be specifically in the liver or the gut, or is it only
It's not going to be
specific?
what? I'm sorry, say it again.
The infection of bacteria, does it have
Right.
to be specifically in the gut, or can it be anywhere?
No, it has to be in the gut. It has to be in the gut because it's going to have local effect on the portal circulation. You see, the nitric oxide that will be released will have a local effect on the portal circulation, not on the systemic circulation. Okay.
All right, thank you.
All right. Let's see more. Okay. Anything else? Okay, good. So do you want to start or do you want to take? I mean, it's up to you. Tell me what you want.
I think, doctor, you can start. Sorry,
Okay,
you can continue. I mean,
You want to start?
I'm saying you can continue.
Okay, good. So let's start this. Where is this now? Okay. Right. All right, let's talk about hepatitis. All right, so the liver is usually involved by hepatotropic and non-hepatotropic. So what do we mean by this? Hepatotropic viruses are the viruses, that are, that focus on the liver. Usually they will have, systemic effects through their action on the liver, okay? But they do not infect anything else except the liver. Now, non-hepatotropic viruses are usually systemic viruses that may affect any system really in the body, okay? And the liver actually falls in the crosshair. So it is, what you call it, a blowback, if you will, or a secondary kind of involvement with a systemic kind of infection, a systemic kind of viral infection. Example of non-hepatotropic virus that may actually affect the liver include CMV, Epstein-Barr virus, herpes, and adenovirus. And for the hepatotropic, the stars of the process will be hepatitis A, B, C, E, and Delta. All right, so starting with the morphology of viral hepatitis. So acute hepatitis, as I mentioned to you in the beginning of the first lecture, is usually a lobular inflammation where there is, necrosis, there is apoptotic bodies, there is Kupffer cell prominence, and may give, appearance of lobular disarray. Portal inflammation is present, but usually overshadowed by the lobular changes. Of course, it may actually become very hard to differentiate where the actual process starts and where it is now, as I mentioned to you. The type of cells may help. We know that, for example, acute hepatitis, A is going to be associated with plasma cells. So if you start to see a lot of plasma cells, that may be an indication that the patient is having, this kind of viral hepatitis. Now, chronic hepatitis, as I mentioned to you, is portal inflammation and then spilling over the limiting plate, resulting in piecemeal necrosis and interface hepatitis. Right. So in order to figure out exactly what is happening, you need to look at a number of data, not just rely on, on one, for example, histopathology slide. You need to look at the clinical information. You need to look at the lifestyle of the patient. You need to look at any kind of history of blood transfusion. When did this blood transfusion take place? You need to look at the clinical presentation in terms of acute versus not acute, and you need to look at features that, that you may see in the histopathology slide. Example of that, with hepatitis B, you may see foamy cytoplasm. With Hep C, you may see actually destruction of the bile duct. You may see lymphoid follicles. You may see also some mild fatty change. Immunohistochemical study may help you in the process. We have actually immunostains for hepatitis B and the delta antigen that may pinpoint that for you. Of course, serology is going to be also very important, for that patient. If you have a high index of suspicion that this may be hepatitis B or C, you may go ahead and do a PCR, and that's for actually to figure out if there's a PCR. If it turns out to be positive, you may use actually that type of test in order to follow up treatment with what is known as copy number or a quantitative real-time PCR. Okay, so starting with hepatitis A virus. This is a benign self-limited disease. It is actually one of the diseases that is known to be related to the fecal-oral route, usually as a result of the ingestion of contaminated food or water. It follows an incubation period. Now, there are caveats for this disease that are important and that have actually a clinical significance. We know, for example, that the HAV viremia is transient. As a result of that, they do not really focus on it much when you are donating blood, because they know that it is almost impossible or extremely rare that someone may actually transmit the virus, by blood transfusion. And also the fact that it does not cause chronic hepatitis or a carrier state. So another very important, another important point for hepatitis A. It is a single-stranded RNA virus which reaches the liver from the GI tract, start to proliferate in the liver cells, but the injury that happened is due to the immune system, by using the CD8 cytotoxic T cells, which kill the infected hepatocytes. For a diagnosis of hepatitis A, you look for the IgM. That's a very important point. In a lot of actually tests, you will see this is coming to ask you about how to test for hepatitis A. It's still valid until our day and time now. So you look for the IgM hepatitis A viral antibody, which is the best diagnostic marker for the disease. So the measures for prevention and management of hepatitis A is going to be public health management in terms of hygienic practices, in terms of disposal of human waste and personal hygiene. There is also passive immunization with immunoglobulin for person at high risk for infection, very young, very old, and immunocompromised, or after exposure to the disease and administration of inactivated virus vaccine given either before exposure or shortly thereafter the exposure. And when you look at a hepatitis A under the microscope, you will see portal, periportal, and lobular areas. Remember the cells that are going to be the plasma cells, in that region. You may see also some cholestasis here and there. Now, a very important point is, when does hepatitis A become a problem? So obviously, it's not really a problem unless it is one of the super severe form of the disease that may result in necrosis and may result even in death. But that happens in less than 1% of the cases. So that's not really when hepatitis A becomes a problem. Hepatitis A becomes a problem when it affects someone who have a chronic hepatitis from any source. Let's talk about, for example, someone with hemochromatosis. The patient is living with the disease, okay? So the patient may have actually, developed cirrhosis as a result of the, hemochromatosis. And the patient is able actually to live with the disease, hard, but it is it is happening, and then hepatitis A, come and infect that patient. Hepatitis A in this case is going to break the compensation of that patient and may actually result in the demise of this patient. Okay? There will be liver failure, acute liver failure that may kill the patient. Similar thing to what you see, for example, in autoimmune hepatitis. Someone with chronic hepatitis B or C. So what do you do in this case? That's when you should remember this part right here. Immunization. So you immune in order to save your patient from the second shoe dropping. Okay. All right. So now the second one will be hepatitis B. This is a huge problem even after actually we have done, we have come up with the vaccination. Excuse me. So even after the vaccination development, there is still about, if you believe that, 300 to 450 million people living with the hepatitis B. They have different names for them. They call them chronic carrier, chronic active carrier. All you need to know is that they do have the virus in their blood, and if it is absent from their blood, it is actually present in their liver. It is transmitted by blood and almost all other body fluids. And the leading causes of this kind of infection are IV, drug abuse, and unprotected sexual activity. Now, one thing I want you to look at this nice figure that comes to you courtesy of Robbins, and look that the majority of cases, and I apologize for this once again. Put that here. So the majority of cases are going to result in recovery. Look at this. So it is chronic hepatitis C, chronic hepatitis B. This is what everybody have in mind. But there is always an acute hepatitis. Now, the acute hepatitis, could be actually subclinical, or it may actually manifest as acute disease, regardless. So let's say that subclinical disease, meaning the disease happened, but the patient does not really, know that it is happening because the acute disease is very mild. That happens in about 60 to 65% of cases, and about 100% of those patients will go on to have full recovery. Let's say that acute hepatitis happened in those patients. Of course, it will be a nerve-wracking, experience for the patient, for the family of the patient, and for his clinicians. But also with acute hepatitis, about 99% of the time, it will result in full recovery. Very few cases go on to cause chronic hepatitis. You can see only 4%. Okay. So that's a very important point to keep in mind when you differentiate between hepatitis B versus hepatitis C, which is going to be exactly the other way on. Now, this is some of the exercises that I got from, I believe, when I got it, it was from either the NIH, I think it was the NIH website, yes. So this is just to actually try to interpret some of the results that you do for patients with, or for people who may present with serologic markers for hepatitis B. So starting with a negative result for hepatitis B surface antigen, and also for the core antibody, and also for the surface antibody. That tells you this is what you call actually a virgin, person. Why a virgin? Because this patient did not really get to meet hepatitis B yet, and was not vaccinated against hepatitis B. So practically this person is susceptible to infection. So what to do with this patient or this person? You ask him actually to have the vaccine that is going to prevent the infection. Okay. Now, one actually caveat here is for and still to this day, this is a valid actually definition. You define chronic hepatitis B as the presence of hepatitis B surface antigen for 6 months or longer. Very important point to be kept in mind as well. Okay. Now, coming to the second, person here with these serological markers. Hepatitis B surface antigen that is negative, the core antibody that is positive, and the surface antibody that is positive. Once the person gets to meet hepatitis B, even though the person may actually develop the immunity from the infection, so immune due to natural infection, the core antibody will be last long, will be there in the blood of this patient forever. Okay. So in this case, the surface antigen has been lost, which means that the patient is no longer actually chronically infected. The patient did develop neutralizing antibody, but the stigma, if you will, that this patient was actually infected with this virus at one point in time is the core antibody. Okay. Now the third exercise is going to be with someone who have hepatitis B surface antigen that is negative, core antibody that is negative, and surface antibody that is positive. This is a person who is immune due to hepatitis B vaccination. Because what you give, the patient, or what you give the persons, actually, the people, to develop immunity, the vaccine that you give them, is a recombinant hepatitis B surface antigen, which is the coat of the virus. So the immune system will make antibody against the coat of the virus, against the hepatitis B surface antigen. Okay. And as a result of that, that's going to protect against the full infection, and against everything else. And the core antibody will not be there because the patient was not exposed to the core antigen, rather he was exposed to the recombinant surface antigen, okay, and developed, what you call an empty shell, if you will, and developed antibodies to this, surface, recombinant surface antigens. All right, now a little bit more complicated actually results. So you have a positive hepatitis B surface antigen. Once you see that, you have one of two options. Either the patient is acutely infected or the patient is chronically infected. So you need to look at the rest of the, of the results. The core antibody is positive, so that tells you that the patient did meet the virus, was infected with the virus at one point in time. But then you fractionate, the core antibodies, because if always the the antibodies against anything really is made up of either IgM or IgG. IgM will be your clue that this is a recent infection. If it is only IgG, that tells you that this is a remote infection, an old infection. And with the presence of the surface antigen, that tells you that the patient is chronically infected. But here you have actually that the core antibodies are made up of IgM core antibodies, which means that this is a recent infection and the patient has not developed surface antibodies yet. So this is an acutely infected person. So you need to follow this person in time. If you, would like to ask what to do with a person like this, you will re-examine him, retest him for the surface antibody and for the rest of these results here in about a month or two in time. And once you see that the surface antibody becomes actually positive and the IgM becomes positive, okay, I'm sorry, the IgM becomes negative and the IgG becomes positive, and the hepatitis B surface antigen becomes negative, then you go back actually to this area right here, which is immune due to natural infection. Now, the last exercise is going to be with someone who is hepatitis B surface antigen positive. The core antibodies are positive, but the IgM are negative. The IgM core antibodies are negative, which means that the core antibodies are made up of the IgG, which means that this is a remote infection. Okay, and you look at the surface antibody and it is negative, which tells you that if this is actually going beyond the 6 months, that this patient is chronically infected. Okay, chronically infected with hepatitis B. All right. Okay, so what do you see on histopathology examination? Again, it is a chronic inflammatory, a chronic hepatitis, chronic inflammatory process, in the liver. So it will be focusing on the portal, periportal, and a little bit of spillover in terms of piecemeal necrosis and interface hepatitis. There is varying degree of fibrosis that is going to increase as time goes by, because there is no cure for this, so the infection is actually ongoing. Now, an important feature, to distinguish between hepatitis B and hepatitis C is that steatosis is not a feature of hepatitis B, but it is of hepatitis C viral infection. Now, if you take a section of this, actually, of a liver that is infected with hepatitis B, and you look at the liver cells, you will see that the liver cells have what looks like foamy macrophages. Foamy macrophages. This is actually resulting from the presence of the hepatitis B surface antigen that are being made in the cytoplasm of these cells. Now, if you bring in hepatitis B surface antigen immunostain and stain those cells, they are going to come up. Actually, this brownish color is actually going to be the the surface antigen immunostain. So it is telling you that it is actually hepatitis B infection. Another actually picture of hepatitis B infection that is a little bit more chronic, you will start to see this very eosinophilic, round structures right here that looks like it is occupying the place of what used to be a cell. These are apoptotic bodies. So this is actually hepatocytes that have undergone apoptosis after the infection with hepatitis B, resulting in what is known as councilment bodies. Okay? Some of these cells, on the other hand, become so, balloons, so actually swollen, with this, expanding number of hepatitis B surface antigen that is getting made in the cytoplasm, getting assembled in the cytoplasm, resulting in what's known as ballooning degeneration. Ballooning degeneration is a form of apoptosis. Eventually, the cell is going to die, it's going to be lysed, and it's going to die completely as a result of this infection. Now, coming to hepatitis C infection. At one point in time, hepatitis C infection was known as non-A, non-B, because we apologize. Once again. Let's fix that before coming back to it. And then, I'm sorry about that. Okay, coming back to it. So at one point in time, hepatitis C was known as non-A, non-B. We did not really know what was causing it. And unfortunately, it was during that time that it resulted in a lot of infection, especially due to blood transfusion, okay, because you did not have any tool to test for it. So much so that actually in the US and in some countries in Europe, they started to develop what is known as target testing. Target testing. target testing, was done by using actually, some of the tests that belong to another virus, in this case, the hepatitis B virus, such as the core antibody. So they were doing the core antibody, they were doing the ALT, and they were doing the PT. And, by doing these three tests, they were they were trying to make the best guess if the patient have the non-A, non-B, which we know now to be actually hepatitis C infection, hepatitis C viral infection. Now, then, later, so in 1989, when it was first isolated and described, later on, they started to actually develop antibodies. They started to check for antibodies for this infection. And, then we have the PCR, the polymerase chain reaction test for the nucleic acid of this virus. And there are two tests. There is the qualitative test that will tell you if the person has an infection, and the quantitative test, which is going to give you the copy number of the viral particles, which is used usually in the follow-up of treatment. Okay. So now the most common method of transmission in the U.S. is the drug abuse, intravenous drug abuse. And about 4 million of Americans actually have antibodies against hepatitis C viral infections. Now that's important because when you see the word antibodies in the case of hepatitis C, it should not give you any comfort because those antibodies are non-neutralizing antibodies, and you will realize why now in a couple of slides, probably right here. All right, the reason why it is not neutralizing antibody, because there are two regions within the genome of this virus. The first one is the RNA-dependent RNA polymerase, which has a very poor proofreading ability. So it makes a lot of mistakes as it is making the genome of the virus. As a result of that, it will result in a several variants, full of mistakes, the majority of which are going to result in dead viruses on arrival. Some of them are going actually to be functional viruses. So as a result of that, if you test the blood of someone who is hepatitis C positive, you will see that there is quite a number of lineages, if you will, of hepatitis C circulating at the same time. Okay, circulating at the same time, and that could be traced back to one lineage from which everything or all the other copies emerged. So that's one good reason why those antibodies that result from actually this infection are not neutralizing, because they will neutralize the original copy, but you have now copies that are that have a makeup and have envelope protein that will not actually be neutralized with these antibodies to the original copy. Okay, so add the two actually factors right here: the poor fidelity RNA-dependent RNA polymerase, and also the hypervariable region within the envelope of the proteins, worked hand in hand to actually make it unlikely that a vaccine will be developed for hepatitis C. Okay, so two actually points you can take from this is that the antibodies that you see in about 75% in patients with hepatitis C are non-neutralizing antibody because, like, do nothing about it. They neutralize the original copy, but the other copies are no longer actually, are not going to be neutralized by this antibodies. This is one. Two, the hypervariable region is going to work in tandem with this poor fidelity polymerase to make sure that a vaccine cannot be made. Now, if you want to think about a similar process, if you have seen one of those, Air Force pilots when they are hit with a surface to air missile, they release decoys. if you remember that from any of the recent movies. So these decoys in this case are the different variants that the hepatitis C is releasing. It's really a defense mechanism, if you want to think about it, of the virus itself. Why? Because now the immune system is not working only on one copy of the virus, it is working on several copies of the virus. This will ensure that actually the immune system is exhausted. One, two, the antibodies will not be neutralizing. Three, you cannot really make a vaccine against this kind of virus. So as a result of that, you will see that the patient with hepatitis C is going to have, consecutive attacks on their liver that is happening by different variables of the original virus. So you will see that there is episodic elevation of the AST and the ALT, the transaminases of the liver, that are going to be coinciding with the damage that is going to happen from each one of those many different copies of the virus, of the hepatitis C virus, that are present in the plasma of the patient. This is what I mentioned to you, but in written form. All right, so also some actually, a couple of words about the incubation period. There is acute infection. Any disease that you actually read about as chronic disease was actually at one point in time infection. If the patient does not know about it, it's because it was actually subacute to the point that he did not really feel it. And of course, his physician, he did not check with his physician. And as a result of that, he only saw it in the chronic form of the disease. So this is some of the risk factors that result in the transmission of hepatitis C. Top on the list is intravenous drug use, and there's a long list of this. Now remember that blood transfusion now is exceedingly rare. Why? Because we do have actually the PCR testing that will tell you if your blood supply is free of viruses or not. Now, also another point actually about perinatal testing. Perinatal testing, our perinatal transmission, I'm sorry. Perinatal transmission is very big with hepatitis B in Southeast Asia. As a result of that, a lot of the patients a lot of the babies, unfortunately, who go on to develop hepatitis B as a result of, transmission of the virus during pregnancy or during delivery, you will see that they are going to actually develop hepatocellular carcinoma at a much younger age. And the kind of carcinoma that they will develop will be in the absence of cirrhosis, before the immune system was able to mount a response to the hepatitis B virus. Whereas in hepatitis C, that's a pretty rare actually kind of condition. Okay, so perinatal rare in hepatitis C, very common in hepatitis B in Southeast Asia. One thing, as I mentioned to you, I want you to always remember when you come to this, that the majority of the cases of hepatitis C following acute infection is going to end up with chronic hepatitis, with a lot of sequelae in terms of cirrhosis, and possibly also death, as opposed to what you have seen in hepatitis B infection. All right, so what do you see? You see what we have talked about in terms of the lymphocytic bile duct damage. You see also the interface hepatitis. That's when the cells will spill over the limiting plate, start to destroy actually the cells in that site, in that place of zone 1, resulting in interface hepatitis. There's going to be macrovesicular steatosis and lymphoid follicle, presentation, lymphoid follicle presence. Here's example of this lymphoid follicles, as you can see. Now you can see actually that there is what you call a bridging, So this is the portal tract right here. You can see that there are very few ducts that remain intact as a result of the destruction of the hepatitis C immune response in this region. And you are seeing also that there is a bridging activity between this portal tract and the other portal tract, resulting in bridging necrosis first, and then bridging fibrosis, and then eventually cirrhosis. As I mentioned to you, you do the initial test, but the initial test should not actually be only with the hepatitis C viral antibody. Why? Because in 25% of the patients, they will have the disease, but they will be missing the antibody. And the 75% is telling you that the patient, so you do the antibody testing. The patient comes back positive. You don't, tell the patient that you're free of the disease. You will tell him we still need to do. So you do have the infection. Now we want to know if you are actually chronically infected or you have really cleared the infection, which happens in a very small minority of cases, as you recall from here. So resolution, you can see that it's happening only in 15% of the cases. All right. So you will do the qualitative test. The qualitative test will tell you if yes or no, does the patient have the disease or not. Okay. If the patient has cleared this, you will know that your patient have cleared, is one of the lucky ones, one of the 15% lucky ones who have cleared the hepatitis C viral infection. Okay. If comes back positive, then you have to do the next step, which in this case is going to be the quantitative. That's going to give you the copy number variation. You need to also see the genotype because this may direct your treatment nowadays. And you will also be following the patient using, the liver function test. That is the ALT, bilirubin, PT, and albumin. All right, so major complications, of course, the most dreaded ones are going to be cirrhosis and the hepatocellular carcinoma. All right, now coming to the Delta agent. The Delta agent is not really a complete virus. It is a very defective virus that needs the capsule, the coat, if you will, and also the genome, some of the genome mechanisms from hepatitis B. So it can only happen in the presence of hepatitis B infection. Okay. Now this coincidence, if you will, happen in two ways. Hello? Do you guys have a question? All right, maybe I heard my own voice. Okay, so one of two ways for that to happen. All right, so either a co-infection, okay, after being exposed to a serum that contains both the Delta antigen and the hepatitis B virus, okay, all right, or actually a super infection of a chronic carrier of hepatitis B with a new inoculum of hepatitis D. Now, most actually of the patients who have a co-infection, who get exposed to serum of hepatitis B and the Delta agent, are going to actually clear the viruses and recover completely. The reason for this is that the competition between the two viruses, and especially the Delta on the HBV for its coat and for its genome, is going to weaken both, and that's going to allow the immune system to simply destroy both of them at the same time. The most likely, scenario of a chronic carrier of hepatitis Delta antigen, infection with, hepatitis B is if it happens in the form of a super infection. So someone who's already a chronic carrier of hepatitis B and then gets exposed to the Delta agent, that's going to result in the majority of cases to that's going to result in the majority of cases to infection with the two viruses, okay? And that's going to result to more severe chronic hepatitis and very possibly actually liver failure in a short period of time. So it is a worldwide kind of infection, and the rates vary actually, but a rate that definitely should be kept in mind that it can be as high as 40% in Africa and the Middle East. How do you test for the Delta agent? That's going to be looking for the IgN, testing the IgM, antibodies for the Delta agent is going to be the most reliable indicator of a recent Delta agent exposure. Now, acute co-infection by the two, you're going to be finding actually IgM that is directed against both the Delta agent and the hepatitis B core antigen, as you recall from the exercise that we have done. In case of a super infection, then in this case, you would see that, for the patient to be labeled as a chronic hepatitis B, the hepatitis B surface antigen has to be present in the serum. And you may see also that the Delta agent antibodies, both the IgM and the IgG, are going to be present in low titers in the serum 4 months or more. Now we're actually going to discuss hepatitis E, very similar to hepatitis A, but it does have actually a little bit of, kinks, if you will. So major cause of epidemics of hepatitis in undeveloped countries, especially India, is a great example of that. And it occurs usually during periods of heavy rain and monsoons, resulting from, and that's going to result in the overflow of sewage. So it's associated also with the fecal oral route, in this case, on a mass scale. So self-limited, similar to hepatitis A, but it's going to be particularly important when it happens in pregnant women, because when it happens in pregnant women, the mortality rates can be as high as 20 to 40%. This is some of the bacterial, parasitic, and helminthic infection of the liver. So a list that I trust actually the clinicians to be going over them. I just wanted to list them here for you to keep them in mind. I think the most exotic ones are going to be the echinococcal and the amoebic. And I believe Dr. Abul Khair is going to be covering them in details. All right, so now the autoimmune hepatitis. So in this case, actually, it is a diagnosis of, it's a pretty rare condition. So as a result of that, it's a diagnosis of exclusion. You have to rule out the more common, actually, viral infections before you actually go to diagnose this kind of disease. Now, there are some features for this disease, including female predominance, as you all know. This is what is seen with autoimmune disease. Absence of the viral markers, dominance of the immunoglobulin G, and there are also other autoantibodies present, such as the anti-nuclear antibodies, muscle antibodies, anti-mitochondrial. It's also associated with higher frequency in people with HLA-B8 or HLA-DRW3. And as you all know, it happens in tandem with other autoimmune diseases. So you will see that the same patient is having Hashimoto's, having vitiligo, having type 1 diabetes, and so on and so forth. All right, now the real deal, if you will, the alcoholic liver disease. The 3 stages: the steatosis, the alcoholic hepatitis, and then the alcohol-related cirrhosis. So these are the stages. You can see that there is a lot of actually two-way kind of arrows telling you that there is a chance of recovery. But then when it comes to cirrhosis, you can see that it is actually going in one direction. Now, believe me, Robbins and probably Gulgin are scratching their head, because there are a lot of recent papers that, I would not say a lot, but there are recent papers that actually speak about recovery and resolution of cirrhosis. That cirrhosis is not really an end stage condition, that there are actually, reports, I would say good number of reports that show that cirrhosis has reversed back into steatosis, possibly even into normal level. Okay. Lo and behold, this is what is the most recent news now. Now, one thing actually I wanted to always, pathology is the science of digging. And, one of the questions that should come to your mind is, what does alcohol do to the liver? How does it cause its injury? A lot of people will tell you, we actually drink socially, and that should be no problem. Actually, that's a very loaded word, because social drinking means a lot of things for a lot of people. So as a physician, when someone actually mentioned this name for you, you have to make sure what they are drinking, and two, how much they are drinking. Okay, so the amount and the frequency are very important in this case. It's true that there are actually people who are able to, process large amounts of alcohol with absolutely, no sequel, and they do live, to, older age. But it is an established fact that alcohol is a toxin, alcohol is a mutagen, and also a carcinogen, as we will say. Okay. So how does the liver work on alcohol? How does it, metabolize it actually? So this is the alcohol. It works actually in the liver. It works on it. The liver cell works on it in three different ways. One, using the cytochrome P450, the 2E1 variant of it. The second one, using the alcohol dehydrogenase. And the third one is the catalase. The end result of each one of those, reactions is going to be the acid aldehyde. Now, that itself also is a huge problem because the acid aldehyde will result in what is known as the adducts. And the adducts, again, are carcinogen and mutagen and toxic, substances to the liver. Again, this actually, these pictures, come to you courtesy of osmosis. So I want you to know that, but, the narration is mine. All right, so now you see actually that in the middle reaction right here with the alcohol dehydrogenase, you are seeing that the alcohol dehydrogenase uses NAD as a cofactor, a coenzyme, to produce the acetaldehyde. You guys know anything about the NAD? How about this? Is it good or bad? Very simple question. Wow.
Good in what sense?
It's good for the cell, good for life. It is very good for the cell and very good for life. So it is actually what is known as the anti-aging substance. Right? Now there are tons of products on the market that, I'm not telling you to buy it. I'm just telling you that they know now actually the importance of the NAD. Okay, and it is really an amazing thing that the alcohol is using up the NAD, showing you that it is going to result in the aging, in increased aging, if you will, of the cell in general. Okay, so not only that it is using up the NAD, but it is resulting in the production of the NADH. So your question is going to be, what does the NADH do? This is actually how the fat deposition in the liver happens. So if you ask yourself, how do we go from alcohol abuse to alcohol liver disease? It is really the deposition of fat. Okay, of course, the alcohol there's really a multitude of factors that will result in actually damage to liver cells, but one part of it is going to be the production and the deposition of fat in the liver. Before actually fatty livers, we used to know that only alcohol that will result in fatty change in the liver, that's going to be followed by alcoholic steatohepatitis, that may actually also go on to develop into alcohol cirrhosis and possibly also hepatocellular carcinoma. That's before. We know now that fat could do the same, but fat in this case will be a lot milder than alcohol. Why? Because it actually is going to be working on the deposition of fat in the liver itself, right? But it will not have the other the other, what do you call it? The other attributes of the alcohol, toxic attributes, mutagenic attributes, and carcinogenic attributes of the alcohol. Okay. Now, NADH is going to be accumulating, and that's going to result, that's going to propel the cell to make more fatty acids that are going to start to get deposited in the liver, resulting in fatty change in the liver first. That's going to, continue to result in, alcoholic steatohepatitis, maybe also complicated by cirrhosis in the long run. Not only that, but also the same reaction is going to result in the formation of reactive oxygen species. And you guys know from, this is a list of the reactive oxygen species, what the ROS do in the cell, correct? They have tendency to actually go after the proteins, under lipids of the membranes and mitochondria and the DNA, the three most important, components of the cell, the genome, the membranes, and the mitochondria. And the rest is history, as they say, because this itself is known to be causing, cell damage, irreversible cell damage, possible also, transformation into, hepatocellular carcinoma. Now, if that is not enough, then there is an added, actually, caveat to the action of alcohol in the same reaction itself. The acetaldehyde, once it starts to accumulate, will aggregate with itself, creating what is known as the adduct. Now, that itself is, in itself, a mutagen and a carcinogen. Now, and also will result in the demise of the liver cell. Why is that the case? Because then, once it's formed inside the cell, it's going to be actually presented on the membrane of the cell. That is going to be recognized by a macrophage, that is going to be brought to the site of action, and the macrophage will take care of that, liver cell presenting this adduct, this acetaldehyde adduct. So in a nutshell, in everything that results from alcohol, whether it is the reactive oxygen species, the NADH, or the adducts, are going to result actually in irreversible cell injury and possibly also, highly possibly, cellular transformation. All right, so now we know that experimental animal models have provided convincing evidence that alcohol is a mutagen and that acetaldehyde should be regarded as a carcinogen. And where do you see that the most, the alcohol and the acetaldehyde? Usually in the upper aerodigestive tract. So this is where cancer of the upper aerodigestive tract are related to the use of alcohol and acetaldehyde. How does it do it? This is a very important new slide from prior years. How does the alcohol mediate its mutagenic effect? One, through forming the adducts. Two, oxidative stress, as you have seen. Three, it's going to induce the Kupffer cells. We have talked about what the Kupffer cells do when they get induced. Inhibition of DNA methylation, and then impairment of retinoid metabolism, which is needed for cellular differentiation. And that's going to keep the cell in an undifferentiated state, which is going to make it exposed for cellular transformation. Now, the acetaldehyde itself will exert its mutagenic effect by interacting directly with the DNA and causing lesions within them, point mutation within them, from point mutation all the way to extensive chromosomal damage. For example, the acetaldehyde will induce point mutation in the hypoxanthine phosphoribosyl transferase gene, which is going to impair DNA synthesis, repair mechanism, and that's going to actually result in unstable and disintegrated genomic DNA. The end result is going to be this acute change in the liver. Here's actually the liver steatosis on a CT, showing you how huge it is. Sometimes reaches 4 to 5 kilos. And you take a section of this, you do also reticular stain and the blue stain. This is the reticular stain, telling you that the patient is starting to have actually cirrhosis. All these actually cells are having what is known as macrovesicular steatosis as a result of the accumulation of fat. You know now from the prior slides how fat get to accumulate in the liver. As I mentioned to you, there are the star cell of the alcoholic hepatitis is actually the neutrophils. And here you see that there are actually the presence of lesions with these neutrophils. The neutrophils itself are going to destroy the cells that show evidence of damage by alcohol or by fat that is accumulating as a result of the alcohol damage. And the damage in the cell is going to be in the form of the accumulation of the Mallory hyaline structures right here, which is an intermediate cytokeratin filament that is seen in alcohol-related disease and other diseases as well, but it what you call highly pathognomonic, but not specific for alcoholism. Here's an example of the end result of the use of alcohol with the presence of what is known as the micronodular steatosis, because the nodules of this cirrhosis are pretty small in size. There is some coalescence here, but the majority of them are small in size. So this is showing you, the end result of the fibrosis process that will follow the damage to liver cells by alcohol, and that's going to be micronodular steatosis. And that's going to be the end of it. Any question about this lecture?